Zuzair with us, who will be sharing his experience of his student days of PharmD and also as a clinical pharmacist. So I have been associated with him for very long, and I have a good relation with him. And there are certain qualities which I really like and appreciate. So one of them is his humility, and the other important thing is the gratitude, even for little things. So he expresses that gratitude, and those are two good qualities which will help anybody grow. So with this short words, I ask Zuveria to formally introduce Zuzair, and then Zuzair can proceed with this talk. So Zuzaria,
Yes, sir. Very good evening to one and all. This is Jueria. Today we are having young, dynamic, and brilliant speaker Dr. Juzair Sabuwala with us. Dr. Juzair have completed PharmD, Doctor of Pharmacy, in the year 2021 from Sultan Ulum College of Pharmacy. During his internship, he was able to complete training under various specialities, actively involving in therapeutical treatment plan of the patient during ward rounds. In mid-internship, Sir was called upon to work as a clinical pharmacist in Aware Gleneagles Global Hospital, LB Nagar, Hyderabad. Sir is actively involved in providing the best care to the patient and taking quality initiating process in pharmacy practice. He is also appointed as assistant professor in Avanti College of Pharmaceutical Science, Hyderabad. Sir have been an important part in NABH assessing teams and has been awarded by the NABH assessor with the best pharmaceutical care provider and a clinical pharmacist, and also appreciated for providing the best pharmacological care. Apart from academics, Sir is also actively involved in social work and have been awarded as a change maker by the US Consulate General for working on debunking of fake news. We are eagerly waiting to listen from you. Over to you, sir.
Sir, can I start?
so Zuzair, so congrats for that. I was
Thank you
looking
so
to break
much.
this news during this live session. So recently there was an NABH inspection, and some top doctor from one of the reputed institutes was the assessor, and he was so happy with Zuzair, and he in fact praised him and truly understood the value of a clinical pharmacist. And one more thing, Zuzair, I think you are the first one out of the mentorship students to be taking a session. So that is one more of an achievement, especially in 2022 mentorship program. So welcome and over to you. Okay, you can continue with you.
So, good evening, everyone. Before I start, I would like to thank Dr. Karthik sir and Team Avenida for giving me this opportunity. I truly understand the efforts it takes to, arrange the session and give this opportunity. So thanks to Alvin and Karthik sir for this opportunity. So before I showcase what a clinical pharmacist can do in a hospital, I would just like to, show my journey of how I went through PharmD before starting what role we can play in hospital. So before starting it, I was a very confused head, to be honest, when I was in my second year of PharmD. So while I was doing my, in our second year itself, we had 1 day of hospital visit. So I used to, out of my interest, I used to go to another hospital that was nearby my house. And there I used to sit along with the consultant and attend his rounds. So initially, I think there was no communication between me and him. And even he had no idea about what a PharmD is and what his role can be. So one fine day, actually, he just spoke to me and he asked me, like, in pregnant women, what is the dosage? Like, do you increase or decrease the dosage? So usually many of us tend to answer that we decrease the dosage of the drug, most of it due to toxicity. But I answered saying that we sometimes increase the dosage. The reason behind is the body fluids in the body of a pregnant woman is more. So the drug distribution will be more. This was my answer. And sir was pretty happy. And there is where my journey started. And sir had invited me to his hospital, that is Olive Hospital. and I was able to go along with sir in his rounds for the third year, fourth year, and fifth year. So in my second year, when I used to go to the hospital, even I was very confused about what our role in hospital would be. We were told that our role is just related to adverse drug reaction, and I used to study only ADRs of the drug, go to the hospital, try to find out ADRs that are there, and just report it, write case sheets, and come back. So this was my role, what I used to do initially. Then I can say that I was the most luckiest at that time when I met Karthik sir. It was in a Novotel conference where it was an IPA meet. So I tried to hide from him. I still remember, because that time we did not have that much of knowledge, and it was difficult for me to communicate with him, but I put up that courage and I met and I interacted with sir. Then I was able to attend sir's module, summer module is where I met sir, and I was able to attend. So there I came to know what a true role a PharmD can play. So there is I truly feel that there is where my journey started. I started learning in depth concepts, starting with diseases, therapeutical management, and going on rounds with consultants. This had helped me a lot. I will be sharing in detail what our role in the hospital would be. Okay, so I have a presentation that I would be presenting. So I started working, and in my fifth year, I was able to work on a clinical project that was very basic in everyone's view. But I think in the summer internship, I had known the importance of that value. That is the basic BMI recording that I did of the patients, and stratified the patients in the age group and the complications that the patient might have. So this was a part of the project that I did. I did 2 publications in my fifth year. Then came my sixth year, and I was able to attend various departments, from general medicine to pulmonology, neurology, and I was able to contribute significantly. So after my presentation, I would be sharing few major clinical interventions that I had done and that had helped, and basically they were life-saving interventions. So during my sixth year, after 4 years of 4 months of internship, I was called upon by Glengale's Global Hospital, as there was opening as a clinical pharmacist, and I had went there, gave my interview, and I was able to crack the interview. So I think I joined there as a trainee clinical pharmacist. The role was that, but I was working as a clinical pharmacist only. After my degree, that is after I got my degree, then I got the job as a clinical pharmacist in Global Hospital. And it's been more than 10 months I have been working there. So every year in hospital, there is NABH assessment. So there are 3 cycles to it. One is review, one is renewal, and one is assessment. So assessment is the toughest one, where the patient, where the hospital should get the new revenue of the NABH that has been already reviewed. So the clinical pharmacist role in NABH, I will just brief out what role we play. So NABH is National Accreditation Board of Hospitals. So that is introduced by the Quality Council of India. So it is a quality marker of how a hospital is practicing. So in this, the clinical pharmacist plays a major role in medication order management. It is also known as MOM. So the medication order management is how the patient is given the drug and how safely medication practice is being followed. So this is what we concentrate, and our role, the clinical pharmacist role, is there in the hospital. So while my presentation, I'll be showing the various interventions that I did, and also share the NABH interventions that I was able to share it with the assessor, because the assessor was happy to find the the interventions that were life saving. So what happened was the assessor found out in their hospital there was a death due to that drug, and we were able to revert it because of the safe clinical practices that were being done. So this was the reason why the assessor were very happy with the audit that went in our hospital. And then what was his response was, he said that this is the best clinical pharmaceutical care that is given to the patient, and he requested the management to provide a department of its own, so indirectly hiring more clinical pharmacists, and that is indirectly giving more jobs to PharmD. So that was the goal basically. And we are in plan, and hopefully we will be getting new PharmD recruits in our hospital. So this is the point where I always remember Karthik's statement, like, do not complain for that there is no jobs, but try to create some. So, sir, truly, I believe the words that you said, and I hope to practice it one day in the similar ways. So I would like to show you all the presentation of what roles a clinical pharmacist can do in a hospital, so that I think will give you a better picture on how on a daily basis a clinical pharmacist should practice in a hospital. It's just not ADR, adverse drug reaction. It's a lot of components into it. Along with the presentation, I will be sharing few aspects that we do practice in NABH assessment, that is National Accreditation Board of Hospital, for the quality management of the patient. So, sir, can I start sharing the screen, sir?
Yeah, yes, sir, go ahead.
Thank you, sir. So I hope this was what I have done in my internship days. So before I got selected in the hospital, I was able to portray the kind of work that we can do in hospital by showing this presentation. So the areas that were covered during the internship, like the areas where a clinical pharmacist can work, were untreated indication. I will be going in detail for all the indications. Okay, one is untreated indication. Next is inappropriate drug selection. Third is subtherapeutic dose. Fourth is drug overdose. Sixth is drug interaction. Seventh is drug duplication. Eighth is treatment without indication. Ninth is pharmacoeconomical evaluation. 10th is transcriptional evaluation. 11th is ADR identification. So ADR identification is a part of role that a clinical pharmacist plays in the hospital. It is not just, our role is not just related to ADR identification. 12th is administration errors, and 13 is treatment without indication. So these are all the areas where a clinical pharmacist can work, and this is where we can change our through our clinical knowledge and pharmacological knowledge, we can bring about change in the treatment. So first is untreated indication. What does untreated indication means? So this usually involves the identification of the patient complaints that is related to the drug related indications that has been ignored. So here the vigilancy of the clinical pharmacist might help to prevent this error. So this was a 65-year-old male patient was admitted to the hospital with shortness of breath and muscle cramps. So the patient was continuing on Losar H, that is losartan and ARB, and hydrochlorothiazide, that is a diuretic. So usually patients have cramps are commonly due to dehydration. So the patient was having cramps, and there was no clinical intervention that was being done for the cramps, and that was creating a lot of pain to the patient and uneasiness. So it was known that there was no role of the diuretics that was being used in the patient, and the patient was stopped with hydrochlorothiazide, and plain losartan was started on the patient. And after even in a single day, what was seen was patient patient complaint subsided, and he was cramps free. So this was one intervention. Next is inappropriate drug selection. So this is where there is with the information, knowledge that a clinical pharmacist can possess can provide a better drug selection in the therapeutic regimen rather than the other drug that has been selected. So there was a 55-year-old patient with MRSA, that is methicillin resistant staph aureus infection. So usually whenever a patient is admitted with MRSA, the choice of drug for MRSA is vancomycin, linezolid, ticoplanin. So the patient was started on vancomycin, but the patient's serum creatinine was deranged. As you can see in the report, it was 2.2. And vancomycin is considered to be nephrotoxic. It is nephrotoxic. So that is the reason why here what intervention was made was, instead of vancomycin, ticoplanin or linezolid could have been used. So this was one intervention where a clinical pharmacist, through his pharmaceutical knowledge, can advise a better drug when compared to the drug that is being used. So the next is subtherapeutic dose. Subtherapeutic dose. So this is where I would like to share the incident. So we used to just study the dose according to the weight of the patient. And this was after the module and the internship that I attended, where Karthik sir had specified regarding the various weight that is present. Like, first of all, BMI calculation of the patient is extremely important in the hospital. It is important to find out the BMI of the patient and to stratify the patient is whether the patient is underweight, overweight, and all. So based on that, the patient ideal body weight can be calculated, and the ideal body weight of the patient is different for different gender. It is lean body weight can be calculated, and this calculation, so there are some drugs that whose dose has to be decided based on the actual body weight, and there are some drugs whose dose has to be calculated based upon the lean body weight. So this important point, after knowing this important point, I was able to bring significant changes in the therapeutic plan. So this was a patient, a 75-year-old male patient with complaints of SOB, and was identified with pocket site infection. So pocket site infection is where the pacemaker is placed. The pacemakers are commonly placed in the clavicular area. So there was infection for this patient and was found to be resistant to all the antimicrobials. So polymyxin B, being the last resort, was used. The drug is usually mentioned in form of lakh. It is not mentioned in form of million international unit. So here, as you all can see, polytough 4.5 million international unit is being mentioned, but it has to be mentioned in the form of lakh. So this was a transcriptional error that I will be discussing in the coming cases. So here the patient weight was 105 kgs and the patient was obese. Okay. So I was able to calculate the BMI of the patient. Usually the polymyxin B vial is one vial has 5 lakh units, and based upon the weight of the patient, I calculated the total body weight. You can see here the total body weight is 105 kg, and based on that I calculated the ideal body weight of the patient. And after calculating the ideal body weight of the patient, the dose of the patient that the patient had to get was significantly less when compared to the dose the patient was getting. And here it was very less when compared to the patient was getting. So this was a subtherapeutic dose. Uh, Already the patient was resistant to many of the antimicrobials, and one reason for which there is resistance for the antimicrobials that is being started for the patient is subtherapeutic dose. So what happens is usually whenever antimicrobials are used in a subtherapeutic dose, that carries a risk of causing resistance. So this was a risk factor, and the dosing of the drug was changed. And one important thing to remember is whenever we go for change in the dosage of the drug, or whenever we change the therapy of the drug, it is very important that we go based on evidence. Because right now we can see that evidence based medicine, that is EBM, is the most important form of medicine. And you can portray your points only through facts. You cannot just go and tell this dose is less, this has to be given, this has to be not. So here I have downloaded the monograph of the drug. So the monograph of the drug, you can find out the monograph of the drug through the FDA guidelines of the drug that has been used. And the monograph of the drug, here you can see, states that use actual body weight and adjusted body weight for obese. So here the patient being obese patient, so the body weight had to be adjusted. And this intervention was brought to the notice of the consultant along with proper evidence, because this is the most important part. Whenever we approach a consultant for any change in the therapy, one thing important to remember is it should be based on an evidence, and if it can be supported with a clinical study, that is, if you have any trial that shows the superior nature of one drug over another, is where you can strengthen up your point and put that point in front of the consultant, and then he will always welcome your opinion. It has always been true with me, because whatever rational changes that we plan to put in the therapy, it has always been welcomed with all the consultants that have came through. So it is very important that we back our data through with the help of clinical studies and also evidence based. So this is core important thing that a clinical pharmacist should know before approaching a consultant for the change in therapy. So here it was found out that the patient was given polymyxin B at a dose of 4.5 lakh units per day diluted in 100 ml. Patient BMI was calculated and was found to be 33. And the patient was stratified into grade 1 obese, and accordingly the calculated based on adjusted body weight. So the dose was reduced and the proper dose was started for the patient. So this was the significant intervention that was done, and this was welcomed by the consultant. So it is important to know what drug has to be given with what body weight. That is, you have to find out the BMI of the patient. It is very important, because the drug is always given based on the body weight or drug body surface area. These are the two important aspects we should be knowing before studying the monograph of the drug. Next was drug interaction. So a drug interaction can be identified as an interaction between two chemical drugs that are used, and when it is an interaction, it causes decrease or increase in action, be it pharmacological or the toxic effect of one drug due to interaction with the another drug. So this was one intervention that I was able to find out was patient was prescribed clopidogrel along with esomeprazole, that is a PPI. So it were indicated in a patient where clopidogrel was given within 6 hours. It was given within a gap of 6 hours. So clopidogrel was given at 2 o'clock and esomeprazole was given 8 in the morning. So both drugs are metabolized by CYP2C19. And one important thing to remember is clopidogrel is a prodrug. And A prodrug is a drug that has to be converted into its active form before it has to be absorbed or before it has to show its pharmacological activity. So if there are two drugs that has to be activated by the same cytochrome, don't you think that will create an interaction and that will cause decrease in the active formation of the prodrug, that is clopidogrel? So this was one interaction that I was able to observe in the patient. And two things can be done. Another PPI can be started, that is pantoprazole, where the significant interaction was not seen. Or else the next thing that can be done is the timing of the drug administration can be increased. That is, spacing can be done so that the interaction will be very less. Next is food drug interaction. So here I have many interactions that I have done in hospital. So what can be done is, it is the interaction due to the particular drug molecule with the food particles. So there is a concept known as acetron diet. So what happens, patient usually on warfarin are advised not to take green leafy vegetables along with it. Or if they have to take green leafy vegetables, it has to be taken in moderation. So why? The reason is warfarin works by inhibiting vitamin K dependent clotting factors, and green leafy vegetables that are given that patient consume are rich source of vitamin K. So this is a significant drug interaction, food drug interaction, that has to be taken care while the patient is on acetron or warfarin. So the next important thing, food drug interaction that I was able to find out was in Parkinsonism patient. So usually what happens is, Parkinsonism patients are started on levocarbidopa. That is, in Parkinsonism, there is always deficit of dopamine. So we give levocarbidopa drug in these patients. And the important thing to remember is, for the absorption of levocarbidopa, there is a transporter. So the same transporter is used for the transport of the protein that is taken in our body. So what happens, consider you going in a bus, okay, and you have already you have already taken your seat in the bus. Now your friend comes and tries to grab a seat, but it has already been taken by you. So you can travel, but your friend cannot travel. So this is the same case with the transporter. Instead of drug, if protein is taken along with the drug, what happens is the drug will use up the transporter, causing decrease in the absorption of levocarbidopa. And in Parkinsonism patient, dopamine is the most important drug. Levocarbidopa is the most important drug to be given. So this is a significant interaction that has to be taken care of. And here what happened was, in this clinical case, the concerned nursing staff was administering the drug, diluting it in nephro-HP powder. So usually in emaciated patient, that is weak patients, we usually give them protein powder diet that is rich in protein, so that what happens, that emaciation is overcome. So the drug was diluted in the nephro-HP powder and was being given. So this was a significant food drug interaction that we can overcome in working in a hospital. So here the next is drug duplication. It is very important to find out. Duplication is the administration of the same drug. So here what will happen is, a patient might be seen by one or more consultants. So a drug that is being written by one consultant of one brand name, the similar drug might be written by another consultant with other brand name. So what happens, usually we use brand names in hospital, and that practice has to stop. and that is one core aspect of NABH, where they ask that only generic name of the drug has to be written and not brand name. So this prevents the duplication of the drug. So this duplication usually happens due to the same drug being given of different brand names. So here, this was a case where patient was being given, you can see here, it was Dolo. Along with that, again there was Helfenac P. Again, P is paracetamol. Here, the dose that was total cumulative dose that the patient was getting was less than 4 grams. That is the safe dose of paracetamol. That is why there was no significant interaction or significant ADR that was seen for the patient. But this has to be avoided, and this can be done with thorough knowledge about generic name of the drug. And a clinical pharmacist should audit all the drugs, okay, looking out for the generic name of the drug and the generic composition of the drug. So here you can see the next part is pharmacoeconomical evaluation. So apart from the clinical knowledge that clinical pharmacist should possess, it is the pharmacoeconomical evaluation that has to be done by a clinical pharmacist. So always trying to reduce the economical burden of the patient should be the first priority. Okay, so this can only be done after having thorough knowledge about even the cost of the drug. And this has been the recent field that has been booming even in abroad, where pharmacoeconomical evaluation of the drugs have been given very much importance. So here there was a patient that was admitted for cervical lymphadenopathy. That was again MRSA. So MRSA means linezolid was being given. Okay, so what happened was, in this linezolid, the patient was given all the drugs, but all the drugs were in oral form except the antimicrobial, that is linezolid. So the cost of each linezolid injection is 650 rupees. It might be of different brands, the rate might differ, but on an average, it's 600 rupees. So the dosage is twice daily. So it comes to around 1200 rupees. So the patient has to pay out of his pocket 1200 rupees. And now the patient was absolutely normal. Like the patient was in a condition to take oral medicines. Oral linezolid tablet has a cost of 35 rupees. Yes, it is significantly, variable, that cost. And in a day, the cost will come around 70 rupees of linezolid. So yes, so the important thing to remember is linezolid, here you can see, is rapidly and extensively absorbed after oral dosing. That is, the bioavailability of the drug after oral and IV absorption is the same. Very important thing. So here I was able to present the consultant with this clinical evidence, that is the monograph of the drug, and the drug of the patient was shifted from IV to oral. So this saved around, consider it is 150 rupees. Maximum it is 70 rupees in a day. Yes, 70 rupees. And if it is IV, it comes around 1300 rupees. Yes. So we are saving around 1230 rupees of a patient in a single day. So that comes, usually linezolid is given for 7 days. So you can multiply by 7 and you are saving around 7,000 to the patient. This can be done only with thorough knowledge about the absorption and the pharmacokinetics of the drug. So it is important that we should know the pharmacokinetics of the drug, and this can be practiced. Next is transcriptional evaluation. So here I will discuss about what a role a PharmD has to play in NABH. So NABH is National Accreditation of Board of Hospital, and the role of clinical pharmacist in NABH is MOM, that is Medication Order Management. We should make sure that the patient is getting safe medication at safe dose in a right way. So this is very important, and it has to be made sure either by a clinical pharmacologist or by a clinical pharmacist in the hospital. Along with this, there will be a mom nurse that will be working along with a clinical pharmacist or clinical pharmacologist, trying to provide patient the best possible pharmaceutical care. So what does NABH states is, it is not possible to say everything in in this session, but I will try to brief out about what all clinical pharmacists can work in NABH. So the major aspects that a clinical pharmacist should work in NABH is starting with uh, differentiation of look alike and sound alike medication, creating a list and providing it to all the staff, that is nursing staff. So look alike, sound alike drugs, so that will prevent any errors for the administration of the drug. So we will help in creating a look alike, sound alike list. Next thing is, we will be auditing for the capital letters a prescription is written. We will audit whether dose is written. We will audit whether there is a route that is being mentioned, abbreviation, proper abbreviation that is being used. So all these preventive steps will prevent any medication error that will happen in the hospital. And through NABH, a clinical pharmacist can perform these activities and prevent any error that might happen to the patient in the near future. So as it is, always prevention is better. So that is why we do this as a clinical pharmacist. It is our role to do the audit and try to reduce the abbreviational error, try to reduce the transcriptional error, try to reduce the prescription error, try to reduce the dispensing error. Dispensing error is what a pharmacist dispenses. So they might be different drugs that they might dispense, and that is what will cause dispensing error. So this is all comes under NABH practice, and that will increase the quality of the medication order management, and that will avoid any errors that a patient will face in the hospital. So yes, this is transcriptional evaluation. This is the wrong dosage that is being written, wrong route that is being mentioned. So here you can see Astor. There is one drug that is Tazlac that comes under 40 mg, but here it is being written as 400 mg. So this dose being unrealistic, there was no error in administration, but if there might be any minor changes in the dose, that might lead to wrong dose administration to the patient. And this is our role to find out any transcriptional error that is being done when the notes are being changed to the medication chart or the progress notes. So this is what a clinical pharmacist does in the hospital. Next is Adr identification. So this is very important. So this is, I think, what we used to think is the major role of a clinical pharmacist in hospital, but this is a part of our JD. So this is a part of our job description. So here I was able to find out an ADR that was due to lactic acidosis due to metformin, and we were able to stop metformin and start another oral hypoglycemic agents. So next is the administration errors. So there might be various types of administration errors. So the first one is incorrect dilution. So here you can see that previously the case was polymyxin B was diluted in 100 ml NS, whereas the drug had to be diluted in 300 to 500 ml NS. So what happens is per ml, the dose of the drug will significantly vary, and that will affect the kinetic of the data of the drug. Kinetics of the drug will be affected, and that will change the absorption of the drug. It is very important. Next is timing of the administration. So this you cannot say as an intervention, but can say as a safe medication practice. Usually statins are given during the night time. For atorvastatin, half-life being less, should be given during night time. For rosuvastatin, half-life being on a higher side, can be given in the evening hours. So the reason why is the production of the viscosity of the blood usually increases during night, and the production of the fats increases during the night time. So that is the reason why statins are to be given during the night time. Next is patient on alpha blockers. So this was one important incident that had happened, was patients usually started on alpha blockers have syncopal effect. That is, they will experience syncope, that they might experience any falls, and that might cause significant damage in older section population. That is, older population, they might experience falls. And one of the major cause of hospital falls, drug related, is alpha blockers. So usually alpha blockers is given during the night times in initial phase. After the patient is, has been using alpha blockers for a longer period of time, the patient can be, the administration can be changed from evening to morning hours also. But initially it should be started with given during the night time. This concept is known as first dose effect. That is syncopal effect due to alpha blockers during initial administration time. It is very important to know this. Next is method of administration. It is very important to know that what will happen is some of the drug has to be given over a specific period of time. So here there is a drug that is vancomycin, and vancomycin has to be given over an hour, preferably 2 hours, but over an hour. So what happened in this patient was vancomycin was given within half an hour to the patient. And vancomycin being a drug that if given in within half an hour or very quickly might cause urticaria and rashes due to histaminergic response. That is, due to increased histamine levels, there might be rashes all over the body of the patient. And this concept is known as red man syndrome. So what management was done in this patient was given vancomycin slowly, and that reaction subsided with its use. So I would come to the last point of my presentation, that is treatment without indication. So what happens is whenever a drug is being started for an indication, so after it might be started empirically to prevent increase in infection or to prevent worsening of the condition. So what happens after the drug report comes, the drug in case of antimicrobial should be de-escalated, or in case of special conditions like in this case where the case of there was fever, pyrexia of unknown origin, and rightly empirically it was started on RT3, that is anti-malarial drug, okay, injection emal, RT3 and RT-sunate. So what happened was after the report of malarial report, even after coming to know about negative report, the drug was continued, and the drug was continued in the patient. So this is where a clinical pharmacist can work, and the treatment without indication can be stopped. So this is what I had in presentation to show, sir. So this is what a job role a PharmD can do, and this is a part of it. So can I share few incidents that had happened in hospital
Sure,
that.
sure. Yeah,
uh,
please. So don't disclose
so
identity details and all. You can just share.
yes, sir. So there was a patient who was on rheumatoid arthritis, and the patient was being usually these patients are started on methotrexate, and the dose of methotrexate is it has to be given weekly once. Starting dose is weekly once, 7.5 mg. So what happened was it was transcribed as daily by mistake, and that before that dose was given, it was audited by the clinical pharmacist, that was me, and I was able to stop that administration of the drug. Most important thing to remember about methotrexate is it is highly toxic to the liver, and along with it, it is also used in medical termination of pregnancy. Most important point. So 2 grams of methotrexate, cumulative 2 grams of methotrexate, if given, might cause cirrhosis in patient. So this toxic the drug is. So this is a narrow therapeutic drug. So I was able to revert the orders to weekly once, and this happened in the discharge summary. So this is very important because after once the patient is being discharged, it is not easy to track the patient. So this was, we were able to revert this. So this was one significant intervention that I was able to find. And the another intervention that was able to change the patient's pharmacotherapy, clinically significant, I would say, was a patient that was on ventilator, and the patient was started having recurrent seizures. So the cause of recurrent seizures was not known. Patient was on phenytoin, tablet phenytoin, and along with that, patient was having GI bleed. So for the bleed, patient was started on antacids. Sucral was being given to the patient. And what happened was, after over a week period of time, there was recurrent seizures even after giving high doses of phenytoin and other anti-epileptic drug. So what I was able to find out in this was, usually in case of drugs, we try to find out the therapeutic drug monitoring of the drug. So the TDM of phenytoin was done, the trough concentration of phenytoin was done, and after that it was found out the drug levels of phenytoin was significantly low. And then there was found to be a clinical significant drug interaction with sucralfate. So sucralfate prevents the absorption of phenytoin. And what was done was, phenytoin was changed from oral to IV form in that patient. And there was the seizures subsided, and we were able to revert the condition. And this was done after finding out that significant drug interaction. It was just due to an antacid, but the interaction was significant as the patient went to ventilator due to recurrent seizures. So this was one intervention that we were able to find out and benefit the patient finding out the intervention. So in our hospital, whenever we find any intervention or any errors, so we have the habit of classifying the errors. So in the hospital, what we do is we classify the errors based on its severity, based on the MCCP guidelines. So there are different categories. It would be difficult to show it now, but there are different categories from category A to category F, that is not significantly affecting the patient to significantly causing death of the patient. So these errors can be divided, and this can help us to find out where we stand in the pharmaceutical care or the pharmacological care for the patient that we are providing. So these were the some intervention that was being done, and these were the significant intervention that we do. So in the hospital, apart from this, We also do counseling only for the medication part. So here is the important part, that we shouldn't be counseling regarding the disease of the patient or medical condition, but we should be focusing on the medication part, that is the administration time, the route of the administration, and what might be the diet, that is significant interaction that might be seen with the diet. Then only we should be commenting on the diet of the patient. If it has to be, interaction with the food that with the drug that the patient is taking. So patient counseling has been one important role that a clinical pharmacist can play, that is patient medication counseling. And apart from this, the core role is in antimicrobial stewardship. So the most important part a clinical pharmacist play is, along with antimicrobial stewardship, is the escalation, de-escalation of the antimicrobials, trying to use the best rational antimicrobial for the patient for the best possible duration with help of the pharmacokinetical data. So this will improve the care of the patient and also try to reduce the resistance that the society is facing. Because right now it is being said that in the near future, if this is the pattern of antimicrobial resistance that is being continued, a single E. coli infection can kill a patient. So that significant role is there of resistance in antimicrobials, and that can be reverted in a hospital based setting with the help of hospital infection control team, of which a clinical pharmacist is a major part of. So this is the various role and aspects a clinical pharmacist plays in a hospital alongside a clinician. Yes, we will be supported, and this support will be getting only if the recommendation that is being done is rational and being backed up by an evidence that might benefit the patient. So yes, sir, this was what I wanted to share regarding the role of clinical pharmacist that can be done in hospital.
Yeah, excellent, Suzanne. So we will take one or two feedbacks. Does anybody want to share feedback what you so far based on what you have learned? You can unmute and give your feedback.
I'm Satyasree. Sir, first of all, I would like to thank you for patiently explaining us everything along with examples. And your interventions are they're really good. And knowing that you have two publications in your fifth year was it's really great. And also, thanks for explaining all the interventions in detail so that we can understand them. And thanks for uh, giving us suggestions about MCCP guidelines or NAVH major three aspects and all, sir. Learned a lot from you today, sir. Thank you so much.
One more.
Sir, hello, sir. Thank you so much for this session. Firstly, I'm Yashvi. I'm in fourth year, and we have just started our regular postings and stuff. There are many things that I knew already, but like I just knew the names. Like what it include was just known by this session, and there are many things like many interventions that could be made, and that I got to know by listening to you, and it was really great. The session had much like very qualitative session. Thank you so much. Thank you really.